Welcome back. So, did you have fun discussing the case? I hope so. So, let's see what we thought about doing. Our treatment plan consisted, first of all, in an initial phase of therapy, where, of course, you go through scaling and root planing, you go through conservative treatment of the different teeth, replacement of the existing crowns with provisionals, at the existing vertical dimension occlusion, and then we do a first reevaluation. At that point, we thought about going ahead and investigate the orthodontic option. So we went through the ortho prosthetic setup. The assumption was that the upper left baby tooth had to be removed. As I showed you before, we went through our orthodontic analysis. This is the initial appearance of those 6 variables, and this is what they suggested to us. So she has a flat profile. We don't want to make it more flat, so we need to give the support to the lip, which means we cannot move palatally neither the upper nor the lower teeth. As a matter of fact, the lower teeth need to be pushed out a little bit. We need to align the teeth and properly and close diastemas. We would like to actually try to retain the canines in that position. As far as class 2, we will accept it because at the end it's almost as if it's a class 1 if you look at the premolars. But we will see what is our intention about the left side in a second. And of course, we will try to align also the lower midline to the upper midline. So orthodontics came to our table, and of course we need to define the general aims of the orthodontic therapy together with the orthodontist. So certainly we need to expand, align the arches. We would like to open vertical dimension occlusion to make space for our restorative materials, and this also will influence the length of the front teeth. We need to correct the inclination, the mesial inclination of the lower molars, and make space for the proper size of implant crowns and implant supported crowns. We need to reduce the discrepancy of the midlines, and of course we want to close the space that is existing in the upper left quadrant between 14 and 16. So basically we came up with 3 possible scenarios for our patient. Scenario number A is the replacement of the upper left canine and with an implant, and we are not going to do any orthodontic movement mesiodistally of the maxillary arch. In scenario B, instead, we were thinking about advancing the left side so that the 2 sides, right and left, would be symmetrical. This is definitely not easy, but this is what we were thinking about doing, and then by opening up a space in 15, we would place an implant there. Scenario C was instead the distalization of 11 into its proper position after the extraction of the baby canine, and then the replacement of the lateral incisor on the left side with an implant. So what are the considerations regarding scenario A? Well, basically the considerations about this possibility is that it's the quickest therapy. We still need to do orthodontics to close diastemas and maybe also to align better the gingival margins of the front teeth to get them more harmonious. Certainly, by maintaining the canines in that position, I have a challenge in making them look similar, which is not that easy, but not impossible. Scenario B, instead, is the scenario where we extract the baby canine and then we move mesially the teeth on the posterior teeth on that side. It's certainly a type of movement that is difficult to carry out. It requires skeletal anchorage and it takes a long time. And also there is a high risk of root resorption. And still, I keep the canines in the lateral incisor position. I still have the same challenge. To move mesially posterior teeth, nowadays we can use this type of skeletal anchorage. We have started to use this in the last couple of years, and it's extremely effective. So it is possible, but it takes time. And then we have scenario C. And scenario C is the one that contemplated moving distally the canine into its proper position, and then the replacement of the lateral incisor with an implant. This also is a type of movement that requires skeletal anchorage, but it should be easier than scenario B. Then there is the issue of placing an implant in the front, which has to be done in an exact manner. To make a long story short, this is a scenario that we actually chose. And you will see my considerations at the very end. So here we are starting orthodontic movement. Then during the therapy, the deciduous upper left canine was removed. And then slowly we moved back, we pushed back 11 into its proper position. Once we were satisfied with the medial distal position of the canine, then we also did the orthodontic uprighting of the lower molars to prepare the sites for the placement of implants. And we placed the implants both in the lower and in the lateral incisor. Once they were ready, we placed provisionals, screw retained provisionals, and finished the orthodontic therapy and put some retainers. And this is the time of the second reevaluation. We left enough time for things to settle in and mature, and then we were able to, after about 3 months, to carry out the final phase of treatment. And at the end, I always deliver a night guard, which is also a removable retainer for the upper teeth, and then we place our patient in a maintenance schedule. So the therapy was carried out by my partner, Matteo Capelli, as far as the surgical phases are concerned, David DeFranco, the orthodontist, myself, the restorative dentist, with my dental technician, Luca Vailati. So this is the situation after initial phase of therapy. We placed provisional crowns in these teeth, and I cemented them with a permanent cement to start then orthodontic therapy without worrying of them coming off. And we started the distalization of the canine, but very soon we realized that we really need skeletal anchorage because the midline of the upper arch was moving to the right. So we placed this type of TADs, as you can see, and with the help of this TAD, then we were much more effective in distalizing the canine without moving around the other teeth. Still, it was a long therapy. In the meantime, in the lower arch, we were aligning teeth, closing diastemas, uprighting the molars, and preparing the sites for the placement of implants. We did some regenerative therapy. I'm not going to go through all of that, but at the end we placed 1 implant on the right, 2 implants on the left. This x-ray was taken at the time of uncovering of the implants and placement of healing abutments. The first of the 2 implants on the left side did not have the healing abutment properly placed, then we fixed it, but I did not take a new x-ray. Now, the orthodontic therapy was carried out to harmonize the position of the teeth according to the gingival margins, not the incisor margins. So this is the way the patient appeared to me once we were fairly happy with the movement of the teeth and the leveling of the gingival scallops. So this is a typical case where gingival scallops guide the movement of the teeth and the hand of the orthodontist, because he knows that then I will align the incisal edges properly. So again, at the end of the orthodontic therapy, or close to the end, it was apparent that the height or the length of the teeth on the left and the right side were not correct. And so I went ahead at one point with some direct composite to finalize their dimension so that the orthodontist could then finalize his job by just placing the teeth both mesodistally and apicocoronally in the right position. This is a time in which we also went ahead and placed our implant in the lateral incisor position. As you can see, the distal movement of the canine really left a very nice edentulous edge. Very generous amount of bone was basically left behind. And we placed a single implant. We still did some regeneration because on the buccal side, as you can see, there was exposure of the threads. So we totally covered the implant, and after about 6 months, actually longer than 6 months, because she had moved to Paris in the meantime, so it took us about 12 months before we were able to uncover it. And here's the situation with the implant supported provisional in the position of the upper left lateral incisor. And soon after this slide, we removed the appliance, and this is a situation as she was debanded. This is a panoramic radiograph taken by the orthodontist at the end of therapy. And this is a superimposition of the two side films before and after, according to the cranial base. So indeed, there was some opening of the occlusal vertical dimension, which I was really counting on, and this, of course, allowed me to lengthen the upper teeth incisally a bit to give them a proper size. In the meantime, we realized we had some periodontal issues which needed to be addressed, and we did it at this point. So we did some crown lengthening on the upper left quadrant, and after we did that, we had an issue with the palatal surface of the first molar, which eventually led us to the decision of removing the palatal root but maintaining the rest of the tooth. And at that point, after proper healing, we carried out the final phase of therapy, and I prepared the upper teeth for veneers. And this is the situation after the cementation of the veneers and delivery of the implant supported crown in the lateral incisor position. So to recap, this is a before and after look of the mouth of this patient, both from the front, the side, and the occlusal view. And this is instead the final set of radiographs that we took at the end of therapy. And when you look at the occlusal analysis, you can see that on the right side, she's still a class 2, angle class 2 patient, because the canine is in the lateral incisor position. But on the left side, she has become now an angle class 1 position. The overbite and the overjet did not change much from the start, even though we augmented the occlusal vertical dimension. The right canine or right lateral movement is a canine guidance, pure canine guidance, and the same can be said for the left lateral movement. Again, a canine rise that excludes all posterior teeth, both on the working and non-working side. And in protrusive, there is a tendency to have the teeth on the right side guide more than on the left side. Now, if you look at the before picture with the dimensions of the anterior teeth of the maxillary arch, and you see the after picture, I hope you can agree with me that there is a better harmony. And this is the way she smiles. There is one thing that really bothered me, is the fact that the Gingiva around 25 was more apical than I wanted it to be, and this is a situation 2 years later, 2 years after the therapy, and things did not really change much. And these are some other views of the 2-year follow-up examination, where everything seems to be stable, did not really change much. The occlusal contacts also are fairly well defined and present on all posterior teeth, and certainly I had a happy patient. But I think after a case like this, you need also to take advantage of this documentation to look back and critically analyze what you did to make sure that indeed you did the right thing for this patient. So what are my final balance considerations? Certainly, first of all, the length of time of this treatment was humongous. It took us 6 years. 6 years is a huge amount of time, and never before I had such a long period of treatment time for a patient. This was due to two factors. Certainly, the type of orthodontic movement played a role, but also the fact that this patient, unfortunately, was not living in Milano, but was living in other cities, and then at one point she moved abroad, and so she was coming back very seldomly. Generally speaking, David sees his orthodontic patients once a month. With her, we diluted this to 2 and sometimes even 3 months. So you can understand how that expanded the treatment time. Also, the vertical bone augmentation that we attempted, especially in the lower left, did not succeed 100%. And I'm not too happy about that either, but this is part of the game when you do this type of surgical treatments. The good thing to me is the fact that thanks to the orthodontic therapy, I was able to be fairly non-invasive. On a number of teeth, I did only do veneers or partial restorations, and the lower arch especially, many teeth were not restored almost at all. So this was definitely good and positive. But what about if I were to do it again? Well, if I were to do it again, I would tell you that I would not choose option C again. I would choose option A. I would not move the canine on the left side back to its original position. I will keep it there, and I will try to make sure that I can do as good a job as I can to match the left number 6, the left number 11 with this right number 6. Now, since I did carry out option C, what are the other things I could have done differently? First of all, I would have probably avoided placing an implant in position of tooth number 10. I would have chosen instead a single wing resin bonded cantilever prosthesis because I have done this now for a number of years and I see a very, very good performance with that, and certainly that will allow me, or does allow me, to shorten treatment time very effectively. Also, I would not even in my dreams, wildest dreams, try to attempt to bring 16 in position 15 anymore. We were able to do it, but this really caused a long delay in the treatment. And also you can see from the x-rays before and after, there has been quite a considerable amount of root resorption. The tooth is there, seems to be stable, supports the crown, but certainly I don't feel too good about it, especially if I look at the before picture. The extraction of teeth 17 and 32 would have definitely simplified and allowed us to improve or increase the chance of getting good vertical augmentation around the implants, especially those on the left side. We wanted to keep them at all costs, and then you have technical difficulties in trying to obtain successfully vertical bone augmentation. And also, I think that 25 should have been extruded a bit to try to harmonize the gingival lines in the lower front, but because of the size of the teeth and the loss of papilla, I still would have had some black holes. This is, of course, a minor problem. So I hope you agree with me about some of these considerations. I will ask Michael to update me as far as what you have decided to do. And I thank you very much for your attention and for the chance you've given me to present this clinical case to you. Thank you.